My name is Ryan Lindsay. I am an associate professor of practice here in the Brown School, and I chair the mental health concentration. I have been teaching at the school for almost 10 years now, and as a full-time faculty and as a professor of practice. I think this is my 6th or 7th year. So I'm excited to share my presentation today. So a lot of my work, a little bit about me. I'm trained as a clinical social worker. I'm a licensed clinical social worker. The interventions that I have really become, really familiar with, and, some might say I have expertise in, really have to do with treatment of individuals who've been exposed to trauma, experienced post-traumatic stress disorder, and or the intersection of that with suicidality. And so my expertise really is centered around the interventions designed to help people who think about suicide a lot, create a life that's worth living, but also simultaneously treat unresolved trauma and post-traumatic stress disorder. And so I use strategies such as dialectical behavior therapy. I'm a nationally certified therapist in DBT, but also I also implement and have expertise in prolonged exposure therapy, which is one of our most robust and highly researched PTSD interventions. What I'm going to talk about today is a little bit of the intersection of my work that has to do with why is it so important for us to raise our clinical competencies in suicide risk assessment in order to prevent suicide. And so that's what we're going to talk about today. So I'm going to ground it in the ethical responsibilities of us as clinical social workers, and our role within saving people's lives who are thinking about suicide. So that's what we're going to talk about today. So we kind of think about the cost of suicide. There's lots of ways we could think about measuring costs. One way is financially, another way is emotionally, one way is the cost of the loss of the contributions to our society. And I think about, the reverberations of what a loss to suicide in a family would have. And so before I even get further on, because I'm going to be talking about suicide, I just want us to recognize that this might be a sensitive topic for many of us. We may have our own personal relationship to suicide or have lost a loved one to suicide. So I want to encourage you to use the skill sets that you have to either take care of yourself during, and if you need to log off, that's totally fine too. I just want to kind of recognize that we're going to talk about a sensitive topic here. When we start thinking about suicide and its impact globally, we lose about 800,000 people a year globally to suicide. And when we kind of translate that into, proposed economic burdens due to loss of contributions to the economic states of society, but also the contributions across, globally, in the US, it's estimated it costs around $93.5 billion. And that's not due to the consequence specifically of suicide. It's due to the lost contributions, future contributions economically to our world. Every year, anywhere between almost 10 to 12 million adults in the US think about suicide. Around 3 to 4 million make a plan, and around 1 to 2 make a suicide attempt. And generally each year annually in the US, around 600,000 people receive medical attention due to self-harm or the consequences of a suicide attempt. In 2020, just shy of 46,000 people were lost and families were impacted by suicide, which actually is a reduction from previous years. And men have traditionally died anywhere between 2 to 4 times more often in terms of their rates than women. And so when we kind of think about who is dying from suicide, who's thinking about suicide, who's making plans to suicide, to end their life by suicide, and who attempt suicide, A really important part of this conversation is understanding that there is an ideation to action trajectory. And a lot of what clinical social workers are doing are working at that intersection of ideation to action and our attempts to be able to understand a person's specific risks to suicide and what kinds of factors elevate their individual risk to suicide. And I'll get a little bit into that later. When we can also think about moving this forward is I work a lot with youth and young adults, but suicide is the second leading cause of death for youth and young adults in the US. And there's a high correlation between mental health conditions and suicide. And about 20% of children and adolescents meet criteria at any given point. And most youth who meet criteria for a mental health condition are unaware that they meet criteria for that. The other piece to this is that the vast majority of youth who die by suicide are not connected to services. Only around 60 to 70% of youth meeting criteria for any mental health condition even utilizes mental health services. And only about 20% of youth who die by suicide received specialty mental health care in the previous year. And what this means is that those youth who are connected to services, this is good. And the vast majority of youth who are dying by suicide are actually not connected to services. And that's actually different for adults because many adults who die by suicide are connected to services in a much higher proportion. When we start thinking about suicide as a public health problem, we start looking at putting different efforts and activities into a couple different buckets. And so one way of thinking about this what are our upstream approaches, so our public health prevention efforts that fall into suicide prevention efforts. And that really is a target audience of community and population level interventions that are oriented around first increasing awareness of suicide as a problem in our communities. This is still a big part of what we're trying to do with our suicide prevention efforts is to raise awareness that suicide is a problem. And I work with a lot of school districts, and there are school districts that still believe that suicide is not a problem within their districts because they haven't experienced a death by suicide. But the reality is a lot of people are thinking about suicide, and therefore you are dealing with a problem with suicide. And a big part of the work that we're doing is trying to destigmatize so that we can build awareness. The other piece around this is implementing and putting in place in various systems and structures screening procedures. So the idea here is about not only raising awareness, but the idea that suicide is preventable when caught early and identified early and then referred to resources. And so screening is a part of that might screening implementation within pediatric, family care physicians, to emergency rooms, to school-based settings, to various settings in which there would be screening available, and then referral. So this is looking at the referral network. So not only the people on the resources on the other side of that referral network, but the process of referral. And how do we address the systems that help connect and link individuals who've been identified at risk for suicide to community resources that are available to them now. And then also things that I think about, in here are also, these are strategies and activities that are focused around creating systems and structures that promote help seeking. So I work a lot in schools. And so a lot of the work that I do is actually currently within this bucket. And a big part of that is how do we create school systems that are responsive to the needs of youth who are at risk of suicide. And by responsive, I mean not reactive. And so that we have systems, we have structures, we have policies, and we have people who are trained well enough that when a youth is identified at risk of suicide, that the first thing that we go to is a direct referral to an emergency room, or calling law enforcement or or an ambulance to transport a youth over to a hospital for an evaluation, emergency evaluation. That there are other systems and structures in place that we can be less reactive and more responsive. And a lot of my work centers around helping schools do that, create those policies and practices that promote responsiveness versus reactivity. And through that, we increase help seeking. The reality is that if large system responses follow the disclosure of suicidality, it lower, and especially if it's perceived as an over response to their current risk, which happens a lot, then it decreases the likelihood of disclosure in the future because of fear of what would happen if you disclose your experience of suicidality in this moment. And we have federal, state, and organizational policies and practices that drive that, rules, regulations, legislation that is all interacting within our systems and structures. Where a lot of my work, even more of my work, and where my real passion lies is within the second bucket. And this is about raising competencies for conducting suicide risk assessment, intervention, and management. And these are really aimed at the professional level response system. So those mental health professionals who are identified as those individuals who have the competencies and regulatory authority to be able to conduct a suicide risk assessment and implement intervention and design management strategies. So this includes suicide risk assessment. So that's when somebody has been identified at risk for suicide. And so generally this is going to be somebody with a bachelor's, but most likely a master's level degree that has been trained in suicide risk assessment and can implement clinical judgment as part of that process. A range of intervention strategies, including safety planning, and then ongoing management of suicidal ideation and treatment intervention. And so we have lots of regulations that drive the scope of practice of what's available to people in our communities. And then finally, we have a bucket of post-vention efforts. And these are really, again, going back to a public health implementation. Post-vention efforts are the responses to the loss of a person to suicide within a community. The functions of these strategies are really about promoting healing efforts around grief and loss, preventing contagion, creating a system so it promotes help seeking for others that are thinking about suicide, and really connecting and elevating resources that are available in the community. So when we start kind of thinking about suicide as a public health problem, we have there's a lot of work to be done, number one, and there's a lot of ways in which we can intervene across not only our entire career trajectory. For me, I started at intervention, so this middle bucket, and a lot of my work shifted to the first bucket in suicide prevention, mostly because I was working with a lot of adolescent teens and teens who are thinking about suicide and interacting with school systems. And those school systems were making my job a lot harder, but also were enacting policies and practices that were traumatizing, that were re-traumatizing, were making things worse for my clients. And there wasn't a strong system of technical assistance to help schools make decisions around these efforts, where the locus of decision-making often lied was within their legal departments. And legal departments are always going to be exceptionally conservative around reducing the liability, and therefore often less concerned about the human consequences and the emotional consequences of various policies and practices. And so a lot of my work these days now bridges both the first bucket and the second bucket. So why do we need to have suicide prevention as a standard of care? The vast majority of us, if we're functioning as social workers, will interact with individuals who are thinking about suicide. And most people in the healthcare profession are going to be interacting with people who are thinking about suicide. And so we know that our roles, by function of our role, we will be interacting with folks who have some of the greatest and highest risks for suicide, just by the nature of the work that we do and the people in which we serve. And so when we kind of think about also why is this so important, is that because we as masters trained social workers or higher provide the vast majority of mental health services in this country, social workers do. And we are assumed by others within the system that we've had the adequate training, so the knowledge, we have the adequate practice, and we have the adequate supervision, real world support to know how to do suicide risk assessment competently and engage in intervention and management strategies. And the reality is that that is not the case. The vast majority of mental health programs, and so that's social work, counseling, nursing, even psychiatry, though psychiatry is the most amount of suicide risk assessment training, and I'll talk about it, but it's slightly different, but less than 20% of programs actually have formal education in suicide risk assessment, other than, and most of it, what it looks like is about a 2 or 3 hour module throughout the entire course of a program. And that's problematic because 2 or 3 hours of something so complicated and complex is inadequate to really prepare professionals to enter the field. And so additionally, educationally, a lot of my work is around advocating for formal programs and coursework in professional graduate training programs to be devoted to suicide risk assessment. And for psychiatry training, which I also do, there is not a formal standard for how people learn, how residents and psychiatrists learn how to do risk assessment and intervention. It is often on the job training, very similar to social workers, where when you're placed within an organization, it is the organization who often, and direct clinical supervisors who teach this. And so the problem with that method of teaching is that it's often the case that new information is not incorporated into the next generation. So as we learn more about suicide risk assessment and what puts people at risk and elevates risk and what helps to mitigate risk, those ideas aren't always integrated into their practices. And so we might, a lot of informal approaches to training often might be reinforcing old ways or less effective means or methods to be able to identify and really differentiate those who are at risk of imminent risk of action versus those that are not. And these are just a little bit of some statistics about who encounters individuals at risk of suicide, but the reality is the vast majority of us will. So one of the things that the 2012 National Strategy for Suicide Prevention really focused on is under clinical and community preventative services, our goal 7 that has to do with provide training to community and clinical service providers on the prevention of suicide and related behaviors have highlighted 2 different objectives. One is getting into graduate training and continuing education, social suicide prevention as a standard core curriculum. More importantly from that, not only do we want in our graduate training programs, but the thing that really drives that are the accreditation bodies for the various professions, but also the industries. And so I'm going to share a little bit about how have licensing and accrediting bodies impacted curriculum around suicide prevention. So currently, most states do not require healthcare professionals, behavioral health or otherwise, so that's including any healthcare professional, to have training in suicide risk assessments. 11 states require training for mental health professionals, not physicians. And 3 states are expanding the definition of mental health professional to include nurses and physicians. So right now, only 3 states are actively trying to expand that definition of those 11. And so we have very few standardized state approaches to get to ensuring that our healthcare profession and workforce is adequately skilled and trained to respond to individuals who are at risk of suicide. The other piece around this is that those standards, whether licensing and accrediting bodies driven standards, vary drastically. So they could be anything from 2 hours, to 1 hour of continuing education to something that others that require 6, like Washington State. It varies dramatically, and therefore what's included and what is deemed accessible and eligible to count towards this requirement varies dramatically. And so the quality of what people are getting are different, but also what people are learning is quite different. And the actual place that has made the most advanced, have taken the most advanced steps, are actually our industry level accrediting institutions. So the Council on Accreditation, or the Joint Commission, or the Commission on Accreditation of Rehab Centers, all of these have, they regulate our industry and our facilities. So hospitals get accredited by these types of institutions. Behavioral health organizations get accredited by these institutions, and they set specific standards for that accreditation. It is here where the most advancement has occurred, but only in the last 5 to 8 years have substantial efforts around suicide prevention really started to elevate and push forward and require organizations to skill up their workforce and have specific standard of care implemented in place. And so this is fairly new and not very old in terms of our capacity to what have we learned from these processes. And if you know anything about the Zero Suicide Initiative, the Zero Suicide Initiative is really designed to help these organizations implement a comprehensive set of strategies to prevent suicide and reduce suicide to zero within the organization and the community that they serve. So some of the things around our ethics across these various professions. So we as social workers, practice alongside counselors, nurses, marriage and family therapists, clinical psychologists, masters in rehabilitation, a large variance of professions that feed into the work that we do, that we all do in a shared way, is that our competency standards lack specificity around suicide risk assessment, although all of our ethics require us to do no harm. And that we need to, and also mandate us to protect the safety of clients using evidence-based interventions and the integrity of our professions. And so a part of what we have to be doing is we need to be, our training programs really need to be banding together to really settle in on how do we train people to enter this field, and how can we get a standard baseline in which all graduates, master's level graduate students from these various professions are entering the field with similar knowledge bases. And then as we enter the field and learn more, we begin to hone and expand and deepen our understanding of how we can interact and prevent suicide. Oops. And so some of the things that are really important to be able to get into training programs in terms of comprehensive suicide prevention competencies for training programs have to do with understanding definitions of what suicidal behavior is, So that's helping to understand that there's a difference from thinking about suicide, from planning a suicide, from attempting suicide and dying by suicide. These are defined differently. Also, there's a difference between non-suicidal self-injury and suicidal behavior. There's a difference between suicidal behavior and risky behavior. That we understand the differences between that. We understand various risk and protective factors that elevate a specific either community or population of individuals' risk for suicide, or protective factors. We have to understand our relationship to suicide and how that moves forward into how we interact with an individual who's at risk of suicide. So if temperamentally we are generally risk averse as a human, or have an anxious temperament in general, we often are going to be prompted to have larger fear responses to an existing threat of somebody who's thinking about suicide. What naturally occurs in fear-based responses is that we begin to narrow, and we also become more rigid about our capacity to offer problem-solving options, because part of what we're doing is trying to manage our own fear-based responses in that context. Although the other piece to that is if we've also lost someone to suicide, or we know someone in our life, we've been impacted by suicide in our lives, that personal relationship to suicide is also going to impact our cognitive and affective responses when somebody identifies themselves at risk of suicide, but also how we then go through not only the risk assessment process, but into safety planning. Risk assessment and risk formulation is also a part of this process. And we have to be thinking about how is an individual at elevated risk compared to the general population? How are they at elevated risk compared to the subpopulation in which they share similar characteristics and identity and historical context? And then also, more importantly, and what we have found is that at the individual level, I have to really understand a person's risk status in relationship to their own baseline. So for me, I work with a lot of people who think about suicide a lot. So maybe on any given day, their baseline, if I ask them to scale the intensity of suicidal thinking on a daily basis, on a scale of 0 to 5, 5 being the worst it's ever been, or the most intense it's ever been, generally speaking, a lot of my clients will say they live at a 2. Okay, so they do have suicidal ideation. They think about it at about a level of a 2 on a daily basis, and they have a safety plan in place that helps to prevent action. And so 2 becomes essentially their baseline. And so if my work always centered around doing a suicide risk assessment every time somebody identifies that they're at a 2 again, all we would do in our treatment would be suicide risk assessment and safety planning. What we also know is that if 2 is your baseline, then the existing safety plan is working. And that what I'm really looking for is understanding that when this person might elevate from a 2 to a 3 or 3 to a 4, then I need to reinitiate suicide risk assessment and re-up and revisit our safety plan, and engage in different interventions to see if we can reduce that risk back down to baseline. And that would be a very different experience than working with someone who never thought about suicide before, and they then report suicidal ideation intensity at a 2. If their baseline is 0, 2 is elevated for them. And so then I'm wanting to engage in a more nuanced approach to their suicide risk assessment and safety planning that would be different than if I understand the person's baseline is at a 2. And this is often not what is taught in many programs. And therefore, a lot of individuals who think about suicide, like at a 2, are often treated very similarly to those that may have never had suicidal ideation before and now have that. And those are qualitatively very different kind of people. So So the other thing that we need to understand is that there are evidence-based interventions that reduce risk of suicide and managing suicide in the moment, but also there are very specific evidence-based treatments for suicidal behavior specifically, and that is a specialty practice. We need to increase our public health understanding, both from prevention efforts, upstream efforts, as well as postvention, and then finally, system and organizational frameworks and models. Okay. So there's a ton of information that I just threw at you. That's my entire life's work. So there's 20 years of information that I just shared with you. I actually co-teach an entire course on this, that we spent an entire semester exploring this content and this information. And so I actually want to open up the floor and have some folks jump in, ask some questions, or, maybe share some thoughts on some of the information that I shared. And I'm also a really good instructor, so I can also just call on you because your names are there. You can't hide. So who would like be the courageous individual? Bring forth some thoughts, comments, etc. I feel like Hannah's moving forward, like she's gonna share.
I was moving forward to unmute. Thank you for noticing.
Yes.
Thank you for the presentation, the lecture. I'm curious to know in terms of when we're talking about factors that people demonstrate when they're approaching, I guess, the higher levels of suicidality, more of like a 4 or a 5.
Yeah.
Do you know like the breakdown or percentage of people that just don't demonstrate signs? Because I think that that's something that I'm hearing a lot of like younger people talking about is like, just watching out for their peers. How do I know if my friends are showing these signs? And I'm really curious to know the like breakdown of people that do demonstrate factors or the warning signs and those that maybe don't.
Yeah, and I don't know the exact percentage because I don't think we know that really well. It's very hard to know that. I think the vast majority of people who end up dying by suicide, it feels like a surprise. Because suicidal ideation is accompanied with a lot of shame. So we have so much stigma around our conceptualization of suicide and that connection to weakness, that people keep that information silent and they mask it a lot. And I think it is important to understand that people can appear on the outside like they've got it all together, like things are amazing, but really on the inside, they're very much struggling. And I tend to kind of think about anecdotally, these are individuals who end up in this category of surprise, like we wouldn't have known. These are people who help others a lot. These are people who put all the focus on others. So these are your amazing listeners. These are your amazing problem solvers. These are the people out there getting shit done. And then, but also functionally, because that brings them joy on one hand, but it also functionally sets up relationships so that no one ever asks about them. So it keeps people very lonely in that interpersonal style where they're always chronically helping others, but really a part of that chronically helping others, because it's not just one or the other, is that they get tremendous joy out of that, but they never let anybody in. And so they lived a very lonely life, often is the case, and they engage in a lot of masking behavior. And so that does exist. And I would say the vast majority of my clients that I've worked with, they probably fit in that category. They've been, the benefit is they got access to a service, or they identified, or somebody did notice something, or most of the time they got to me not for that though. Something very unrelated to that. And then we discover that this is also something somebody is experiencing. So it's something that we have so much more to learn about this phenomenon. And a lot of times it's existing, but in a silent way, very disconnected. That's a really good question. What else we got? Comments? Why did we show up today to this lecture? What did we want to learn?
I have a question.
Mhm.
I'm curious if there would be any sort of like practice-based response difference between somebody that maybe was trained as a clinical social worker as opposed to a clinical mental health counselor. Like, is there a, like, boots on the ground, a different philosophy of how you might approach somebody that you suspect of having suicidal ideation or plans?
Yeah, I don't think that there's an actual philosophical by profession. It actually varies dramatically by who are the knowledge holders at those programs. So it is more dependent, and it's more a function of, like, this is my work. I do this work. So it is something I've been immersed in my entire career. So I'm very knowledgeable in this area, so I'm able to bring forth more of that knowledge base. Where in other contexts and settings, the people in decision-making roles that are selecting what is the curriculum and how do we train you is going to be a function of their own training and their own level of knowledge around a particular, behavior or experience or mental health condition or problem that we're talking about. So philosophically and fundamentally, there isn't, at that individual level, conceptually, how social workers are going to integrate and socially locate that behavior within contexts of systems of not only oppression and privilege, but we're also going to be really thinking about how do environmental responses play a very large role in the development and maintenance of suicidal. So for this as a problem of suicidal thinking, and therefore might inform the comprehensiveness of interventions we provide afterwards, beyond just conceptualizing this as an individual level solution. That a lot of my clients, I may have to teach them both how to manage and change their relationship to suicide, while simultaneously recognizing that they're living within systems and environments that are profoundly and pervasively invalidating. And that if that is something we're wanting to shift, because the effect of that invalidation is causing severe misery for you. And so we can raise a set of skill sets around being able to amplify your capacity to manage within that, recognizing that this is a system doing this to you, that is amplifying this. And so sometimes it is, we got to get yourself around, oriented around a life worth living goal, so that you have the skills necessary for you to be able to dismantle that system that's causing that, or advocate for your needs, or figure out a way to engage your social environment to get people to advocate for you, because it's too much for you to do that. And so it's a both and it's necessary. And we're gonna think about this from multiple levels of intervention that is necessary. And oftentimes I will have to say, as a clinical social worker, we're limited in the effects of system consequences. And so we have to, we can't say racism's going away. We can't say homophobia is going away. We can't say transphobia is going to disappear today. Ableism, classism, all the systems of oppression are going away. And so it's a matter of figuring out, how do I learn to live within the existence of that while not approving it, and orient myself towards, a life worth living goal, or some, meaningful activity that may or may not include addressing that. And it's helpful to contextualize that in the absence of these pressures, it is possible that you wouldn't feel this way. I will also say, I don't want to oversimplify that suicide is caused by all these factors. It's a very complicated, intertwined, complex set of variables, and that are unique to that specific individual. So there is no one cause for suicide. There are things that elevate for a person, but it's a part of like springboarding off a set of other factors that we might be able to address too. So it's not just a single layer of intervention. So yeah, that's a good question though. Different programs probably have a different philosophical bent to them as well, you know, of where they're gonna, and what that really means is how different theoretical orientations think about the causes and maintenance factors of various experiences, and then how that translates into what do we think are the mechanisms of change, that what gets towards healing. And so that's just going to look very different. And so we do have a set of evidence-based interventions. What does that mean? They've been through a set of rigorous testing, conceptualizing from formative into, you know, the actual piloting and testing kind of thing. Which does not mean that there isn't a ton of healing, you know, strategies and interventions and processes that are out there that haven't had the privilege of going through that kind of process. The issue becomes, can we offer something that's predictable? And that's really what we're trying to get at when we as professionals are offering a service array, or if we are offering a specific intervention, is there a predictable outcome if implemented within a framework, a frame of fidelity? So a range of how to do this. And there's a lot of ways in which my clients have healed that aren't evidence-based in the scientific way. But, you know, people have been doing it for a really long time. It's consistent with lots of traditional practices. And it's a part of how they conceptualize that. So what other thoughts?
I have a question.
Yeah.
Can you hear me okay?
I can, yeah.
Okay, great. So first of all, I'm curious about what brought you to this type of work and what kind of made you have that passion to help people.
Yeah.
And then I have a question related to how do you think this changes when you're helping people in vulnerable situations like humanitarian situations, people at the border, people that don't have any control over their situation in terms of government institution violence and whatnot. I'm just curious because they have no control over any of these types of things happening to them.
Yeah. So I'll start with the first one. Why am I in this profession? What brought me, I think probably with a lot of people, is, you know, I grew up in the 80s and 90s actually in St. Louis, in a suburb of St. Louis. It was an extremely non-diverse suburb of St. Louis that was extremely Catholic also. I went to Catholic schools growing up. I come from a very large Irish Catholic family. My mom's one of 8, got like 25 cousins. We spent lots and lots of time together, so really strong familial network. And I was a little Gaby here, you know, in this very, you know, conservative Catholic world. And I didn't really feel connected in this world. I didn't have a community. And in the 80s and 90s, essentially, you know, the narrative, the social narrative around, you know, being gay is that I would get AIDS and die, and that was justified because it's punishable by God. So that's the essential stories I was provided. You can imagine that growing up in contexts like that, where you don't see anybody like you in any kind of context, where there are no movies, there are no TV shows, there are no accessible magazines to people, there's none of that. This is pre-internet. There's no going on. I was that first AOL. I was 15 years old when American AOL came on, and I had dial-up, and that was my first connection to the outside world of people like me. But it wasn't until I was 15. And so obviously the consequence to that of not feeling connected, feeling rejected, feeling was not only the shame piece, but I had my own experiences with depression, anxiety. and even suicidal thinking when I was very young. And so I was fortunate that I had this amazing family, and I also had a lot of connections, and I found a community within band. And so I still play music today. Got my tin whistles right here. And I play saxophone. I play in a community band today, still. And I found, a set of, goals I wanted to work towards. And so that helped me get through some very, very, very hard times. And to me, I ended up wanting to do that. I was somebody who was always a good problem solver and a good listener. And so that wasn't my first idea of what I was going to do, but it landed in a world of, I found social work actually because of my sister. My sister is a year younger than me. She did a BSW program. We were at the same school, and I had to take a humanities class or something. And she's like, take this social work class with me. And I'm like, okay. I was psychology and sociology and a lot of anthropology. I'm like, okay, I'll do that. And my trajectory actually was clinical. I was going to pursue a clinical PhD in psychology. But then I found social work, and I'm like, I like this. I like the person and environment understanding. I like looking at these systems. It reflected more of what caused pain for me earlier in my life and even during that time. And so to me, it felt like a better integrated way of thinking. And what I like about social work is that it's not social versus biology versus anything. It's all of it, and all of it matters. And the jury really is still out in terms of figuring out what's the best point of intervention for folks. And it's different for a lot of people. And so I like that about social work. I also like the social justice values that center social work. And looking at, systems of oppression, but also, access. I didn't, even within the system of care that I had access to, there still wasn't anybody that understood my experience, because I was mostly meeting with straight white men or straight white women. Doesn't mean empathy couldn't exist, but I didn't see me, and I didn't see the things that I was experiencing. And I often had to explain some things that I just didn't feel like I wanted to. It's like, I just don't want to do that. I will also say I've had really terrible gay therapists who made lots of assumptions from different generations, where I grew up in a different generation. And so my perspective and the things that I valued and the ways in which I navigated the world were not consistent with the previous generations. I'm kind of on the cusp of where it was completely hidden into a little bit out, a little tiny bit, not where I grew up, but at least from a generational factor, versus where it's very different today. So that's how I got to where I'm at right now. And I think your other conversation or topic area is something that is really complex. I think that, people who are running away from something are able to organize themselves through tremendous travesty and horrific trauma with a sense of betterness that's going to be on the other side. And when so there's that piece to it, and we see that reflected in generational experiences from immigrant communities and refugees communities, where getting here was the safety experience. And subsequent generations where lots of mental health conditions actually start to come about, where assimilation and acculturation actually is more consistent. Which is why we have a lot of interventions focused on ethnic pride and keeping cultural practices in place so that we're not like splitting people's collective experiences. And so I think that in different situations, when people are in survival mode, it's all about, how do I survive? The subsequent, what happens after, the aftermath of these traumatic experiences, once safety, quote, outside of that specific threat has been resolved, then a lot of things happen. And there's a lot of consequences to that. And so, you know, supporting during humanitarian crises we're experiencing right now, not only at the border, we have a war in Ukraine, and there's many other places in the world that horrific things are happening on a daily basis. And that isn't my area of expertise in terms of the global impact. And we do have amazing human beings and faculty members here that do focus in that work. But I think a lot of it is about resources, support, keeping ties to who the people are and their histories. And that helps to prevent onset of a lot of things later on. And that's a really overly simplistic, you know, response to a really complex.
Yeah, it's definitely super complicated, but I was just curious to see what your answer would be.
Yeah,
because it's, you know, very, very relevant today, especially with what's going on and what's publicized.
Yeah, exactly. And I think that one of the problems here is in relationship to suicide is I don't think we know it all. I don't think we understand it. I don't know that if somebody died by suicide within these contexts that anybody would really know. If there's anybody even like asking this question, if there are anybody that is even documenting the existence of what that trajectory would look like through that process. So it's really hard to know, you know, the prevalence, the causes, and then the natural solutions that, you know, are probably already being implemented through that process. So yeah.
Thank you.
Yeah, I appreciate that question. I know Maggie wrote something in chat, so let me read that real quick. Okay, let's see. Yeah, so suicide, thinking about post-COVID. Yeah, I think that, I mean, we do know that suicide rates went down in 2020. We have not seen 2021 data, so we don't know. Missouri data is that suicides were still down in 2021. I think about many of the clients that I worked with and work with, and you know, COVID and the initial lockdowns and that first year, most of my clients became less suicidal during that time period. And a part of why they became less suicidal if they had already been suicidal was because there were less demands. The things that often caused increases in terms of the unique trajectories that elevated their own risks, they weren't interacting as much with certain people in their lives. So it was a socially approved way of disengaging. And so it gave them the opportunity to do that. So there was less interactions that led to that, and there were way less demands on them. I think for those who experienced mental health crises for the first time during the pandemic, it was the first time in their lives in which they were blocked from being able to do the things that they've learned to do that bring them joy. You know, this is a different kind of phenomenon that I don't know that we know. We haven't shared a global pandemic, you know, in the way in which we document and understand mental health. You know, this is the first one. And so I think it's, you know, really, you know, a complicated, we have to wait and see. I do think that when you start looking at the economic impacts and the trajectories or pathways to suicide for many, economics are a big part of that. It's not always the case and not always the relevant piece, but we also know that, you know, it won't only be that. It's just when we have less and we do not have the bandwidth to attend to that, you know, with more and more people, and very specific people. These are not everyone. I mean, like in this US, the economy and jobs rates are dramatically higher, and it's the lowest job, you know, in terms of unemployment that we've seen in like ever. So, but our service industry are industries that were impacted the most, that are not consistent, not associated with access to care because there's not insurance and benefits that are part of those systems. These are the people that are not benefiting from the academic advances of what's happening right now. And the outcome to that, is going to be very different, and lots and lots and lots of traumas that are happening within that healthcare profession. And I spend a lot of time with supporting our local St. Louis Children's Hospital in thinking about methods of healing. And I don't think that there's one way to do that, but I think it is important that we do figure it out, because something's going to happen next, and then the next thing's going to happen. It's not stopping, so we need to figure out more effective and supportive and caring environments for people to work in. Which is why we need social workers trained as leaders running these organizations. All right, it's 2:29, which means my alarm to check in for my flight's about ready to go off, and which means I want to thank you all for spending this hour with me, and I hope I get to spend time with all of you next year or the following year. If you have any questions, email me. I'm available. All right.
Thank you so much.
Thanks, Ryan. Thanks, everyone. Have a great rest of the afternoon. We'll see you soon.